Our keynote speaker this morning is a man of ideas, yes, and boy, he's got a lot of them in a lot of areas. But he's also a person who is just full of energy and drive and putting ideas into action. He taught for a while as a history professor at a college in Georgia. He ran for Congress, was elected, and served as a congressman for Georgia beginning in 1979. He was inspirational and controversial as the architect of the contract with America. That, in 1994, produced the first Republican majority in the House of Representatives in 40 years. He was bold and energetic and determined as the Speaker of the House that passed legislation on domestic and foreign policy, legislation much of which was new and different. It should not be surprising then, I guess, that Newt Gingrich is now tackling health care. And this is not something new for him. He's been interested in this and working on it for a long time. He worked on reforming Medicare in the Congress, improving the Food and Drug Administration, providing long-term care. And he has now established the Center for Health Transformation and written one of the most provocative books on health care that has just been released. The title is Saving Lives and Saving Money. So Newt Gingrich has learned a lot about this, has worked on it hard, has a lot of ideas, some of which, by the way, have a lot of appeal across the party lines. We need strong, aggressive, energetic leaders in this country who will make America what it ought to be and help our people have health care and a good life. Ladies and gentlemen, I am proud to present to you the man who served as Speaker of the House of Representatives and helped change America, Speaker Newt Gingrich.
You know, the governor indicated he was sort of curious how he was going to introduce me. Well, I can tell you, I was a little bit curious too. And that's part of the reason I wanted to come down. I just wanted to see what was going to happen. I have long admired Governor Hunt for his ingenuity, his innovation, his drive, and the fact that he also shares my passion for ideas. And while we might disagree about some details, just to have people who are willing to bring ideas into public life is, I think, very invigorating. And you have quite a lineup of folks coming that have brought ideas into public life. So I think people will have more than sort of like a large feast these 2 days of ideas that will be shown to all of you. I did want to share with you, though, when the governor was going through the introduction, I was reminded of one of the great reality tests of my life. When I was a junior congressman, I was invited to go down to Montgomery, Alabama to do a fundraiser for the then ranking Republican on the Armed Services Committee, Bill Dickinson. And he got to thinking about the fact that nobody back then knew who I was and I might not be a very good draw, so he decided he would have a second person at the fundraiser, and he got Charlton Heston to agree to come. And we went down, did this event, and then after the event they did a photo op, and Dickinson would greet people and he would place them between Heston and me. And then afterwards they sent me some 250 pictures to sign. You've done this many times. And I had the humbling experience of realizing that in 250 pictures, there was not a single occasion in which the woman was leaning towards me. So I always remind myself, no matter how good the introduction gets or how nice the audience is, then there's reality, and it's a different thing. I want to start by telling you about Maggie's purse, because I think I'm going to talk about transformation, and I want to set a framework of what I mean by transformation. Maggie is my granddaughter, who's now 5, and when she came to visit us when she was 3, we took her out and bought her my first purse. And my first purse is plastic. And it has plastic lipstick. It has a plastic keychain. But on the plastic keychain, there is a clicker so you can unlock your car door. It has a plastic comb. It has a plastic cell phone. Now, it's about a 1996 cell phone. This is a new one I just got from Verizon. It's about 3 times the size, and it's open and has big buttons. And she literally walked into the Hotel Washington for lunch talking on her cell phone, because that's what adults do. And she sat across from us, and she wanted to talk to us on her cell phone. We said, we have to punch in the number. Now notice, most of us still say dial. Although, in fact, very few people in this audience have dialed a telephone in a long time. We actually punch in the numbers. I said this in Yountsville, California a couple months ago, and a man came up laughing after my talk and said, actually, his 2 children had gone out to visit their grandparents in the mountains of the Sierra Nevadas near the Nevada state line. And the kids came running out and said, oh, this is really exciting. Grandpa and Grandma have this phone that goes round and round. It's really cool. And they thought it was a new boutique phone that was an option. And so finally, we got her, she would talk to us, and I picked my phone and say, no, you're cheating. You have to open it up, because otherwise you can't talk on it. Now, so I want to set the stage here for a 3-year-old who understands how to use a clicker to get in a car and how to lock a car. She understands how to use a cell phone. And then she had a change purse. And she was going through it, and she suddenly realized that it had a credit card. And at 3 years of age, she looked at it for a minute, and she came over and she said, this white space, this is where my name goes. And we spent the rest of the day trying not to use the word Nordstrom near her. But here's why I'm telling you this story. Here is a 3-year-old who understands electronic clickers, cell phones, and credit cards. The state of Florida last year passed a bill to require doctors to print legibly in their prescriptions. Now, there are 2 things wrong with that. The first is it is a fantasy to think you can coerce doctors into printing legibly. But the second is that the long-term answer to having safe medication is electronic prescribing. And in a world where 3-year-olds can understand cell phones, you could get doctors to electronically prescribe if you took it seriously. And that's an example of the difference between transformation and reform. Reforming is taking the old system and trying to do it marginally better. Transformation is, in fact, creating a new system. Now, I want to walk you through some fairly large ideas, and I just want to pose one thought for you, and that is, when I go through these things, if you could discipline yourself to say yes if rather than no because, you'll be surprised how much opportunity you open up. Now, so you can say, I don't know how to get this done. Yes, we could get it done if, and then you could explain what the problem is. But the difference psychologically between saying yes if, which is an opening up, brainstorming, positive reinforcement, and no because, which is a closing down, negative, and argument-inducing conversation, is surprisingly big when you're trying to get very large-scale change. Now, let me explain why I think you have to have transformation and not reform. I do not believe the current system's fixable. Now, I'm going to start with triangular payments. A triangular payment system where one person is spending the money, a second person is receiving the goods or services, and a third person is providing the goods and services to the second person while sending a bill to the first person. If you just write that out on a chart, just take a blank piece of paper and write that triangle, it is an invitation to a nightmare. Now, if you think I'm exaggerating, I just suggest to you the next time you go to buy a car or a house, take your best friend, give them your checkbook, and say to the salesperson, I'm buying this, they have the money. And watch how confused the salesperson gets. And what happens when you have a triangular payment system? And this is true whether it's a private sector triangle or it's a public sector triangle. the first thing that happens is the person with the money assumes they're being cheated by both. That is, they assume that the individual getting the goods is cheating, and they assume that the individual providing the goods is cheating. So you now have to have layers of paperwork to try to check on the cheaters. But since people are clever, once they figure out you think they're cheating, they feel like they should oblige you. And so they start looking for loopholes, because once you create rules, a rule-based society and a free society is an invitation to find loopholes. It's like a psychological challenge. My best friend used to be a tax lawyer, and his entire specialty was inventing loopholes at a rate faster than the IRS could close them. And he would get a thrill out of staying up till 9 or 10 o'clock at night, finding a big one, and then knowing it'll take 5 years for the IRS to figure out how to close it, by which time he'll have found 3 more. And it was a game. Now notice, if you go to McDonald's and you order a quarter pounder with cheese, you don't feel any need to fill out a form. You don't feel any need to have the State Department of Quarter Pounder with Cheese auditors look over your shoulder. I mean, either the person at McDonald's gives you a quarter pounder with cheese, or you don't give them money. Now, this is not an argument against regulation, by the way. I'm a Theodore Roosevelt Republican. I would like the meat to actually be beef. I would like it to actually be healthy. I'd like the water to actually be drinkable. I think a regulatory framework is a good thing. But I think a bureaucratic framework is almost always a bad thing. So the first point I want to make to you is, unless you migrate back to a binary system, a buyer-seller system, you'll never fix this. It'll just get worse and worse. The second point I'd make is that paper kills. So anytime you hear an argument for why we don't go to electronic health records, that's an argument for killing people. Anytime you hear an argument for why we don't have any kind of electronic prescribing, that's an argument for killing people. The Institute of Medicine estimates that at least 8,000 Americans are killed annually by medication errors. My mother at one point had 3 different doctors prescribing a total of 17 medicines, and I do not believe any of the 3 doctors looked at her complete record. They each looked only at the section they were involved in. Furthermore, a medication error in a study in Rhode Island was the leading cause of emergency room visits by senior citizens. 1/4 of all senior citizen emergency room visits were caused by medication error. The Institute of Medicine estimates that medical errors, mistakes, they're quite clear about this, errors, kill between 44,000 and 100,000 Americans a year in hospitals. Now, I did once have somebody come up to me who disagreed with that, and he said, I don't believe, he said, that's totally exaggerated. He said, I don't believe we kill more than 25,000 people a year. I just stared at him. And he looked at me for a minute and he said, yeah, I guess you're right, and walked off. Now, I'm citing this for a minute because the background that I'm trying to bring to health is that I was the ranking Republican on the aviation subcommittee, and every time we have an airplane crash, we do a tremendous amount of effort to find out why it happened. And I would argue that your life in an airplane is considered by this country to be stunningly more valuable than your life in the health system. And that we tolerate lack of system, lack of electronics, lack of quality, lack of standards in health in a way that we would never tolerate in aviation. And so I want to set that standard for the state legislature, for the Congress, for the professions themselves. I had a story the other day we did a project with Siemens, and they had just gone to barcoding. Very simple idea. We've been using it for over 30 years now with grocery stores. They barcode the individual with a wristband, the nurse with a badge, and the medication. And in going to barcoding, they were looking at how many medication errors does the Danville Regional Hospital by itself have. And their conclusion was they were averaging 119 medication errors a month. And the person in charge of the project went to see the head nurse, and the head nurse said, that's impossible. It can't possibly be that many. I hired these people. I trained them. They wouldn't make these kind of mistakes. So for 3 weeks, they took each morning's medication error report, and they walked the halls to interview the people who'd made the mistake. And at the end of 3 weeks, the head nurse said, we obviously have to go to electronic prescribing, to the barcoding. She said she was crushed by the realization that it is simply human. that a system which relies on memory for very complex procedures is a system asking for trouble. And if you doubt this, the next time you get in a commercial airliner, ask them to show you the plastic card they use for takeoff and landing. Because even if it's a pilot who's done it 15,000 times, they have a checklist. And the reason they have a checklist is people forget. Even people who've done it forever. Even something as simple as taking off an airplane, which is much simpler than applying the right medication to the right person at the right moment in a hospital. So my background is second, the current system has to be transformed because you'll never have a safe, efficient paper system. The third point I make is that the current system's provider-centric. If you had taken all the money we've spent hospital by hospital on electronic health records and you had spent it instead on the entire community, we'd probably have them today. But what we have, in fact, I just ran into this in California, where Kaiser Permanente, a huge system, is buying an electronic health record for their entire system under a process produced by Epic, which is a firm from Wisconsin. And in the same region of Northern California, Sutter, which has 47 hospitals, is going to go to an electronic health record produced by Epic in Wisconsin. And I went to see the two CEOs and I said, have you considered asking Epic to make sure the two systems can talk to each other? And they hadn't at that point, because that's not how people think. And they were literally going to spend billions to bring in the exact same company to produce parallel systems in the same towns that would not have talked to each other without having to think it through from the beginning. So I started with a very simple model, that you ought to think of all of North Carolina as a regional information organization. And you ought to develop a statewide set of standards that are compatible with the rest of the country, but that are initially at least designed to make sure that inside North Carolina, whether it is outpatient care or inpatient care, whether it's the doctor's office, the pharmacy, the dentist, or the hospital, that they can talk to each other. And this is one of the major problems in government today. Fred Smith of FedEx said to me the other week, governments cannot distinguish cost from investment. He said if we had to run FedEx by the Congressional Budget Office rules, we would still have paper, there would be no computers, no wireless, and we wouldn't have a clue where any of the product was, and by the way, we couldn't have founded the company. And I say that because if you just think about it, if you were able to capture how many records in North Carolina will be Xeroxed and either FedExed or UPSed or overnight mail or hand carried this year, it is a staggering number. And if you could capture the savings 3 years from now of not having to do that, you could begin to pay for a statewide electronic system. But as a general rule, governments won't count any savings as having been saved, so everything is a cost, so you can't afford to do the new thing that'll work because you're too busy paying for the old thing that doesn't work. And that's the model of budgeting we're trapped in. Finally, I don't think you can reform the current system because it's not a system. It is a collection of activities with no systematic connectivity. If you go back, if you study Deming and the rise of the quality movement, the first thing they'll tell you is processes have to be systems to have quality. And to be a system, you have to have connectivity. You have to have some ability to say, you know, the patient starts here and ends here, and we don't have that. We have, here's a doctor's office, here's a specialist office, here's the lab, here's the hospital, here's the pharmacy, but they're not connected. And in the spaces in between, all sorts of things can go wrong, and as a result, you can't get the kind of improvement you'd like. So where do we go from here? Our description of this, and what I would urge you to think about for North Carolina, is a 21st century intelligent health system. We use the words deliberately. 21st century, so you can go out to every doctor and every hospital and every community health center and say, terrific 20th century model, let's not fight over it. Now let's talk about what the 21st century ought to be like. And it clearly has to be connected, and it has to be very different in style. Second, intelligent. Now, there are two reasons I like to talk about an intelligent health system. The first is, as a politician, I just like to get in debates for my opponents in favor of a dumb health system. I just think there's a certain advantage to being on the Today Show and being the one who's in favor of an intelligent system. But I think there's also a meaning to the word intelligent. You should be able to get up in the morning and go to the web and pull up your individual health record, and you should know whether or not you're diabetic, and you should know whether or not you're arthritic, and you should be able to pull up the latest information, because we are going to have in the next 20 years an explosion of scientific knowledge and an explosion of therapies and an explosion of best practices, and we should make it as easy as possible for you to learn about you. Because people may or may not be interested about health in general, but people are pretty interested in their own health. They just don't know how to find out about it. And if anything does happen to you, you ought to have an electronic health record so the doctor that you go to knows who you are, what your allergies are, what your health background is. And if you just took the amount of time, if you're my age, I'm 61 now, if you took the number of times in my lifetime I have filled out these forms and just captured the savings of doing it once, so you don't end up with 103-degree fever, slightly confused, being asked at my age, now what was it you had when you were 11? Because the truth is, I don't actually remember. I think I remember mumps and measles, but I don't remember beyond that. And how many of you found yourself in that situation? When you're sitting here in this office, and if you have the right kind of sickness that requires you to go to 4 specialists, you get to fill it out 4 times. This is just plain dumb. So an intelligence system would enable you to know about yourself, to have accurate information captured automatically, and to find out where you should go. And one of the things I strongly recommend is that you pass a right-to-know law that says individuals have the right to know the cost and the quality of every provider. And yes, that's difficult, and yes, we're going to have to invent ways of risk assessment, and I mean, I understand all those arguments. In 1958, the automobile industry hated the idea that they had to post prices. It's a federal law, passed in 1958. By 1999, 14% of the country was going online to check car prices before they bought a car. On average, they were saving 2%. Last year, 64% of the country went online to check prices before buying a car. No federal mandate, no federal training program, no subsidy. People just learned how to do it because it made sense and it was profitable. If we make it possible for people to check price and quality, they'll learn to check price and quality. And the difference will be amazing. Let me give you a couple of quick steps that I would recommend you take up in a very serious way. First of all, because Medicaid is going to be such an enormous challenge this year, I really recommend you look at the concept of a 21st century Responsible Citizens Medicaid Act. And I would start by breaking Medicaid into 4 different programs, one for healthy younger people, one for Americans with capabilities, and I think we need to replace the concept of disabilities with capabilities. We live in an age where virtually everybody can have a much fuller life than we thought of 50 years ago. Disabilities has all too often come to mean warehousing people, keeping them in a dependent paternalistic system, not allowing them to work. It is exactly backwards. Most Americans with capabilities, even if they have problems and challenges other than the ones you have, would like to lead a fuller life of greater opportunity. I also think that's the right way to rethink workman's comp. Workman's comp ought to be about finding out what's wrong, getting it fixed, and getting you back into a full life. Our Declaration of Independence says that we're endowed by our Creator with certain inalienable rights, among which are life, liberty, and the pursuit of happiness. I mean, America is based on a very activist notion that we are pursuing happiness, and I think that we ought to have an approach to capabilities that emphasizes every American's right to pursue happiness. Third, I think we want to think about aging in terms of active, healthy aging and lifetime living, and we want to have the maximum development of expert systems to keep you out of the nursing home. I'll give you one example. There's a little firm in New York that has launched a new product for independent living, which basically uses motion sensors and a neural networking computer. So you have it in your home if you're frail, elderly, but you're still living on your own. It actually gets to know your patterns. So if you haven't gone down and fixed coffee by 9 in the morning, and that's your normal pattern, it calls your children. It says, you know, Mom or Dad hasn't gone to fix coffee yet. If you fall on the floor and don't move in 40 seconds, it calls the emergency service. And it's literally a private sector firm, and it's for people who care about their parents and have the money to do it. And I think it's something like $59 a month. This system is non-intrusive, just uses motion detectors, literally learns the unique habits of your particular loved one, and enables people to have a much closer monitoring without you physically having to drive across town, or if you're traveling, or if you live in a different city. I'm just suggesting that as an example. There's a nursing home, I believe it's in Oregon, that uses a wireless thing that they put on the armband, and as a result, they have an 8-acre campus. And Alzheimer's patients who are early stage Alzheimer's patients can go all over the campus because they can track them in real time. They know where they are. So they maximize their ability to live a decent life while not taking a risk with anything bad happening to them. Now, I'm just giving you those as flavors. If we work at it, we can have dramatically better lives, living much longer with much greater independence, but at some point in our life, we may need assistance and facilitation in doing that. Lastly, we have to look at long-term living in a long-term care facility. And Bob Kerry, former Senator Kerry, and I are now co-chairing a quality long-term care commission, and we're really trying to look at how do we bring all these new approaches and a Deming-style approach to quality and modern technology to that issue. I want to give you just two last large ideas. There's a firm called VisiQ, which does an electronic intensive care unit where they literally wire every room and they monitor 24 hours a day, 7 days a week. They feed the information from every single bed into an office. And they have an intensive care doc and an intensive care nurse, and they're monitoring. On average, one doctor can monitor about 70 rooms. Once you understand the distance doesn't matter, so that the electronic intensive care monitoring for the Guam Air Force Hospital is done from Honolulu. Because what matters is the instantaneous passage of information. There's actually all the data, and there's a camera in every room. What's the result? First of all, the doctor and the nurse in the intensive care observation post pick up precursors of problems 6 hours before the nurse who's on duty, because they have the time to focus on all the data. Second, at 2 o'clock in the morning, the nurse who's on duty facing a crisis is talking to somebody who's already awake. And just changing from calling and waking up the doctor improves nurse retention 35%. Because it's very painful to wake up doctors every night. 3, because the nurse now has somebody she talks to all night, she's not alone. And that improves nurse retention. 4, the families love the fact that somebody cares enough for their loved one that they're watching all night. What's the outcome? They save more than 1 life per bed per year. The mortality rate just drops. They have fewer lawsuits. They have better nurse retention. And people tend to get out of intensive care about 1 day faster per patient. So you can actually get more throughput. One opportunity for a state like North Carolina would be actually to design a statewide electronic intensive care model like that, so that every small rural hospital could participate, where they will never be able to set it up on their own. The parallel to that I think you should look at is the concept of having a similar system, but probably not done quite as expensively, for nursing home facilities. If there was a 24/7 doctor center that nursing home staffs knew that at 2 in the morning when something happened to Mrs. Jones, they could call a medical doctor, you would reduce the number of emergency room visits from nursing homes dramatically. And nursing home visits are both expensive and dangerous for senior citizens. So I just give you that as an example of how we can organize the future. My last comment is on the price of drugs. Drugs are expensive because we designed a system which is a seller's market. Nobody knows what they cost. Nobody pays attention to what they cost. We pay the bill later. The doctor normally doesn't know what they cost when they prescribe it, and the person who goes to buy the drug assumes they cost the copay. So you're getting a $10 drug, or you're getting a free drug, or you're getting a $20 drug. Furthermore, there's no information available easily about comparisons. And when a drug does become cheap, Claritin's my favorite example. Claritin was the second most widely prescribed drug in the world. When it went over the counter and became cheap, what happened? We quit prescribing it by definition. So as soon as you become cheap, we don't prescribe you, and we replace you with something which is expensive, and then we wonder why drugs are expensive. Now, I have a very simple message which I say all the time to all the drug companies. The seller's market is going to be over because, in fact, drugs are now too expensive, and they are too important a part of healthcare to have a seller's market. A seller's market is characterized by no information on the part of the buyer. The only two choices the drug companies have is to go to a regulated market like Europe, or to go to a buyer's market, which I think is much healthier. How would a buyer's market work? How many of you use Travelocity or Expedia or some other system online to look for prices of airlines and hotels? Just raise your hand. Okay, almost all of you. Very straightforward model, right? 24 hours a day, 7 days a week, for free. You go online. You can see virtually every airline. You have to go to JetBlue and AirTrans and Southwest. You have to go to their sites because they won't pay Expedia and Travelocity. But basically, you can find schedule and price worldwide. And you can find it months in advance. And you can make decisions. Here's how Travelocity would work. And one of my goals is to convince enough states to launch this that there's a large enough market that the drug companies have to be conscious of market share and price. Here's how it works. First of all, you eliminate copays. Copays are engines of higher price because when I put in a copay, I assume I want the highest possible price drug for that copay because I think in terms of return on my investment. So if I'm going to buy if I got $10 put in and my choice is a $30 drug or a $70 drug, I'll always pick the $70 drug. I get a 7-to-1 return on my money. Second, copays discourage compliance, and you actually want compliance. That is, you went to the doctor because you need the drug, so we actually want you to get the drug. So what do you have? I would replace a copay with an afterpay, and here's the model. Let's say you need an allergy drug. Let's say there are 9 drugs available. 2 over-the-counter, 3 generic, 4 branded. But you don't have any particular problems, so you can take any of them and see if they work. The way I would design it is your employer or the state, if you're on Medicaid or Medicare, would pay for the least expensive prescription drug, 100%, so we have compliance. If you wanted to voluntarily go to the over-the-counter drug, we would put half the savings in your health reimbursement account or your health savings account, so you're incentivized, if you want to go, try the over-the-counter first. However, let's say last night you saw the ad and it was perfect. It went from, you know what I'm talking about, it went from black and white to color, right? The sound came up. The girl was beautiful. This is your future. This is an open formulary model. You want to put in the extra $193? You're a free citizen, write the check. That model will change purchasing patterns overnight. It will reorient all the drug companies away from marginally better expensive products that they try to get you to buy with very, very good detail people and with lots of advertising. And it'll move them towards investing in blockbusters because blockbusters would actually spread faster and have a higher profit in that kind of system because you'd know about it overnight. It would make that big a difference. Now let me give you one parallel that grows out of the Travelocity model. The current estimate is there will be 2,000 new prescription drugs, about half biologicals and half pharmaceuticals, in the next decade. 2,000. No doctor in the world can remember all the available drugs. And it's a symptom of the last thing I'll mention, which North Carolina could easily be a pioneer in. We have to move to a continuing medical education system which is real-time, online, 24/7, and demand-pooled. That is, when you go in to see your cancer specialist needs to look that morning at your particular kind of cancer and whether or not in the last 72 hours something has happened that changes it. And the reason I say this, we work with the National Cancer Institute. Andy von Eschenbach, the director of the National Cancer Institute, believes that it will be technically possible to eliminate cancer as a cause of death by 2015. That's 10 years. But the only way you can do that is to have a real-time system of discover, develop, deliver, so that the right information is getting to the right person with the right speed, and attached to that, very early detection, early wellness, early prevention, early intervention. Because the earlier we can catch your cancer, the less expensive and the less dangerous it is, and we're going to get technologies that allow us to detect the cancer when it's at the 5 or 6 cell level. Whereas today it has to grow to be a mass large enough to be picked up by some kind of radiological scanning. So I just want to close and go to taking questions by re-emphasizing what I just outlined. You move to the individual, not the patient, the individual, because we want you to practice exercise. And if you look at what you eat, what your attitude is, and whether or not you exercise, we can postpone your being a patient statistically an amazing length of time. So you want an individually centered system. We want to recenter through health reimbursement accounts and health savings accounts so you have an economic interest in your own system. We want to give you the information about yourself so that you can manage your own care, and you can be responsible for staying as healthy as possible because you know what you need to do. And we want to give you the information so you have the right to know who you should go to and what their outcomes are like and how much they charge. And all that should occur in a system in which the doctor is getting real-time continuing medical education and in which you have real knowledge of the therapies that are available and what their outcomes are. I think that's the future. I think we'll get there sometime over the next decade. And I think when we do, we'll look back and realize we really have saved a lot of lives, and in the process, we'll have saved a lot of money. And I think